Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you, Akhtar, for your kind introduction. I'd like first to thank Jamal Belkadir and other organizers who have invited. It's always a pleasure to be in Morocco. And in fact, my MENA region colleagues have been convincing me for the last 10 years to start learning Arabic. And I must say that I think 10 to 20% I've learned Arabic. But I think I got a message today, a soft message from Moroccan League that I have to start learning French as well, which I'll hope I'll try. So I'll be in the next 15 minutes talking about screening and prevalence, prioritization strategies, capacity building, management updates, and future directions in Pakistan. As regards screening, we still recommend that the gold standard diagnostic and screening test in Asians is modified GTT. We do not have enough data in our region, especially in our country, to say that HbA1c shall be used for screening. Right now, we are doing a major survey, and as I speak, we are doing in Pen, Pakistan, a national diabetes survey, which is repeated after 20 years. So the first survey done by Samashera Group, Diabetic Association, was 20 years ago. And this time, we are also having, apart from modified GTT, HbA1c. So we hope by the end of next month, we'll have enough numbers, which is 10,000 plus sample, to say our HbA1c cutoff for diabetes in Pakistan. As regards the prioritization strategies, we learned from IDF consultative sections that we, having millions of diabetic, will have to have resource-dependent or resource-constrained strategies. So we started with diabetes education, diabetic foot, and diabetes in children. In diabetes education, we started a one-year diploma for diabetes education. For the last 10 years, we have been doing it. We have trained 165 diabetes educators in Pakistan. We had the pleasure that our diabetes center was recognized by IDF as one of the diabetes centers of education till 2015. We prioritized for diabetic foot. We had a national diabetes foot program, step by step, funded by WDF. We established 115 diabetic foot clinics in Pakistan. And in these 115 clinics, the amputation rate has been halved. Our plan is to have 3,000 such clinics, diabetic foot clinic in Pakistan. We recently have developed an advisory board for the care of diabetes, which involves 10 teaching hospitals, which are tertiary care teaching diabetes units in Pakistan. We have developed this National Diabetic Foot Advisory Board, which meets virtually every Wednesday 9 a.m. and shares the cases in Pakistan, the one in which we can reduce the amputations through the virtual foot setting. The third was type 1 diabetes. In Pakistan, we have thousands of children who cannot have affordability and accessibility for insulin. So this is restricted to our province of Sindh, in which we have established 34 role model type 1 diabetes clinics, again with collaboration with Diabetic Association and World Diabetes Foundation. This project is called Insulin My Life. And now we are giving 1,900 children who are non-affordable insulin free of cost through philanthropy generated by this project. This got an international recognition by the group, which is called Life for a Child, headed by Martin Schilling and Graham Ogle. And so we are very much part of their collaboration. And in fact, we are now getting free insulin for 500 children from them. And right now involved in genetic studies in type 1 diabetes with Sudan, Bangladesh, Azerbaijan, and Mali. We have recently embarked on Diabetes Registry of Pakistan. We are not as developed as some of the countries we have just heard who already have the registry. We have started with Drop 1. Drop 1 is Type 1 Diabetes Registry. So we have 50 centers in Pakistan who have started to share their data. We have developed an online portal system, and we are expecting to have 4,000 plus Type 1 registered into this registry by the forthcoming IDF in Abu Dhabi. As regards capacity building, because we are dealing with millions of diabetics, a poor infrastructure healthcare system in Pakistan, where 80% plus healthcare is in private sector, we need to train doctors, educators, dietitians, etc. We have started this diploma in diabetology for family physicians. 17 batches have been completed. 400 diploma holders are now practicing diabetes care in primary care setups in semi-urban or rural settings. We wish we could develop a link between these peripheral healthcare centers, as Sandeed has shown in Lebanon. We also are training diabetologists and endocrinologists as a secondary or a tertiary care physicians, and we have got now, it's not 6, it's 8 recognized centers, Penn, Pakistan, where we train them into fellowships. We have recently submitted to the government and hoping that it will be accepted as masters in NCDs. Now, this is perhaps very close to public health, but not exactly public health. What we are trying to get out of it is to formulate or design managers who can formulate and implement preventive strategies. So we expect these as a bridge between the doctors and the patients at various levels. So policy level, corporate sector, institutes, etc., media. As regards the management updates in Pakistan, we never had any guidelines for management through SMBGs or the blood glucose monitoring. So this was a very humble start by our institute and the advisory board, that we developed guidelines which are called BRIDE guidelines about better recommendations, implementations, and guideline development for healthcare professionals and training as regards SMBG, blood glucose monitoring. And if you go through this, which is perhaps a busy slide, but what I'm trying to highlight here is that for type 1 diabetes and type 2 diabetes, there are algorithms, but it also addresses affording and not affording. Both classes are being addressed at the same time. And the way it is, there are 4 tables: lowest intensity, moderate intensity, high intensity, and very intensive blood glucose monitoring, and each have their own indications below. These guidelines have been published and are recently being circulated in other parts of the region, especially, perhaps not exactly the region, Southeast Asia. India actually is interested to know about these guidelines and to formulate their own guidelines in the same for the steps. Talking about diabetes guidelines, this first document was developed in 1999 by Prof. Shera and myself and other parts, which were of the part teams from Pakistan, like National Clinical Practice Guidelines. They needed an update, so we have updated them very recently. They have been sent for publication. They are called Prompt Guidelines, Pakistan's recommendation for optimal care of diabetes from primary to tertiary care level. The beauty of this document is that it involves how to manage the patients at the primary care level, when to refer to secondary, and when to refer to tertiary care level, and vice versa. So this was a heavy job which was done in the last 1 year. We are pleased to say that in MENA Regional Council meeting in Karachi in August 2016, it was taken up by the MENA Regional Council that we develop regional guidelines, and we had this meeting then in Khartoum and recently in May in Alexandria. So this guideline committee was made headed by Professor Samashera of the MENA region, and this document has been presented, and perhaps now is the time when we discuss in the next MENA meeting how to take this document further for implementation. Final part of my talk is regarding the future directions for management of diabetes in Pakistan. We had the pleasure and honor to host a conference in August in which we had very rich international faculty, and I can't take the names of all, but very rich international faculty and national faculty which supported and came to this conference and had their deliberations and suggestions. One of them, which we started after one, was footwear for every diabetic. We say that in Pakistan there are 400,000 people with foot ulcers at one given time. 400,000 people, perhaps more than the population of Qatar for that matter. So we have 400,000 people with foot ulcers, 10% of them having amputations every year. So we lose 40,000 legs in Pakistan every year. So we have reduced, as I showed earlier, the amputation rate, but we now need to reduce the ulcer rate in the first place. So for prevention of ulcers, we need footwear for every diabetic. Now this is a very recent project which we have embarked upon. We are training the podiatrists, or you can call the diabetic foot care assistants, plus the cobblers for shoemaking. And this machine has been installed in Karachi. But in fact, if you could see this pad is being launched in 10 different places, again, the teaching institutions in Pakistan. So the patient or the subject goes there, walks on this pad, we get the digital impression in Karachi, and we manufacture the insoles from Karachi and supply in Pakistan. This is how we are expecting to reduce the ulcer rate in the first place. Talking of diabetes and Ramadan, another important fact which Inas elucidated in her talk, we have got Professor Yaqub heading the diabetes and Ramadan group in Pakistan, and we were fortunate to have Ramadan conferences and, in fact, public awareness programs and educational materials and studies to prove biochemically how we can ensure safe fasting. Now, this international document, practical guidelines developed by Muhammad Hasnan and his group, me and Yaqub were fortunate to be part of it and contributing through our studies. Other important issues need to be addressed is maternal child health and gestational diabetes and the relationship of intrauterine milieu with birth weight and then predisposition to diabetes. Akhtar is here. We are part of this European Union big project, which is called GIFTS. Perhaps we'll have data coming out in the next few months. And what we are saying is that it's the intrauterine milieu, it's the birth weight, which is more important contributing factor. And I hope to hear from Khalid in his talk later on regarding the genetic and the epigenetic interface for high prevalence of diabetes in our part of the world. We were also knowing about the fact of gestational diabetes being ignored or not yet identified in Pakistan. So we developed the GDM Advocacy Board led by Mrs. Noor Jahan Samad, wife of Samashera, and Mrs. Zaida Bakai, Vice Chancellor of Bakai University. We have now developed 3 GDM centers, 20 GDM clinics established in Pakistan. We are expecting to have result of 13,000 screening for GDM this year and another 12,000 next year. After 25,000 screening, we are hoping to develop GDM guidelines, especially how to screen. There is a big discrepancy, as was shown by one of my colleagues, of GDM diagnosed 6% by one method, 14% by another method. We need to identify the best screening test for our own region. And we hope in the coming years I'll be able to share with you data from Pakistan in this regard. The finalist slide, which is important, is when we talk of big numbers, we need to talk of preventive programs, preventive strategies for diabetes. Now, this is a risk score which we have developed in Pakistan. This is published data. It's much the same like an Indian risk score or Canadian risk score or Australian or the German one or the Find Risk which is started from Yakutom Lihetos. The thing is that this is so easy. Within 30 seconds, one can calculate his or her own risk. If the number is 4 or more, this is he or she needs to get checked. He or she is basically having high risk of developing type 2 diabetes. We are now liaising with the ministry to have this in general. Now, we on one hand say Pakistan is a poor country. On the other hand, we know that at least 100 million SIMs of mobile SIMs are being used in Pakistan. So we hope through mobile technology to disseminate this information for launching a primary prevention program in Pakistan. So if we talk of future direction, there are many, in fact, I've elucidated in this 15 minutes. I would like to acknowledge my international collaborators, my national collaborators, and in fact, this is my team which works, and I have shared the data with you. And finally, I'd like to thank you for your attention with this note. that next time if I'm asked to present in Morocco, I hope I'll be having some slides in French. Thank you for your attention.